And on behalf of CME Outfitters, I would like to welcome you and thank you for joining us for today's CMEO briefcase entitled Taking the Long View, Medical Comorbidities that May Shift Treatment Decision Making. Today's program is supported by an educational grant from Gilead Sciences. I am a professor of medicine and microbiology and serve as a chief in the Division of Infectious Diseases and Tropical Medicine at Georgetown University School of Medicine in Washington, D.C. The learning objectives that we have for this session is as follows. How to optimize efficacy and safety profiles of current agents when initiating or switching treatments in patients with hepatitis B. Here is our patient case, and this is Miss Cardi. She's a 58-year-old woman who recently immigrated from Ghana, who presents to her primary care provider for the first time.
Hello, Kadi. I am Dr. Stevens. It is nice to meet you.
Hello, Dr. Stevens. It's nice to meet you too.
Thank you for joining me on this telehealth call today. We like to take a few minutes to get to know our patients before having them come into the office for their first visit and physical examination. It also helps to get a feel for your medical and social history, which may influence blood work that we order.
No problem. It's always nice to have had a meeting so we have a chance to chat first.
So tell me a little bit about yourself.
Sure. Well, I'm 58 years old. I'm a recent immigrant from Ghana. I'm married and have 2 grown children and 1 grandchild, a little boy, Thomas.
That sounds like a nice family. What about alcohol and/or smoking?
No to smoking. I have a glass of wine once or twice per month. I'm not much of a drinker.
At 58, have you had any menopausal symptoms yet?
Yes, I've had some hot flashes and sometimes have difficulty sleeping, but compared to what my sister went through, they have been pretty mild. I do admit that since starting menopause, I've been more tired and don't seem to be quite as strong as I'm used to being, but that's probably age.
Well, fatigue and muscle weakness can be a symptom of menopause, but not always. We don't want to overreact, but we don't want to dismiss it either.
Well, nothing really noticeable. I try to be very healthy and I get out and walk every day. This is probably silly, but I drink a lot of water. But my urine always seems to be dark no matter how much water I drink.
How would you characterize your mental health?
Nothing out of the ordinary.
Okay, well, that's a good start. I'd like for you to go down to the lab to have some blood drawn. I will send an order to the lab for you, telling them which tests I would like to have done. It looks like we have you scheduled for next Thursday at 2 p.m. It was very nice meeting you virtually, and I'll see you soon.
What about Cardi's presentation would change the new patient blood work beyond what you would routinely request, that is a CBC, a basic metabolic panel, and a lipid panel? The United States Public Service Task Force has very specific recommendations for screening for hepatitis B in adolescents and adults so that we can pick out hepatitis B infection in people at risk for hepatitis B. And who are those patients? 1, persons born in countries or regions with moderate prevalence of hepatitis B infection equal to or greater than 2%. These countries are Asia, Africa, Pacific Islands, and parts of South America. 2, US-born persons not vaccinated as infants whose parents were born in regions with high prevalence, and high prevalence is defined as equal to or greater than 8%, and that is mainly from sub-Saharan Africa. 3, HIV positive persons, 4 persons who inject drugs, 5 men who have sex with men, and 6 household contacts or sexual partners of persons with hepatitis B infection. This gives you a geographic distribution of chronic hepatitis B and gives you the countries which have a low prevalence, which is less than 2%, which is mainly the US, Canada, and your Western Europe. 2 to 7% is considered as intermediate, and greater than 8% is considered as high. So in addition to routine blood work, what lab testing would you order for CARDI? So this provides you the test for screening and what the recommendations are for different groups of who are at risk for hepatitis B. So in persons born in countries with a 2% or higher prevalence, the recommendations are that you should order a hepatitis B surface antigen, a hepatitis B surface antibody, that is what is called anti-HBs, and a hepatitis B core antibody, that's what is called anti-HBC. That's the main test that you order. Irrespective of what the risk is, those are the 3 tests that you would order. Her results return as follows. Her hepatitis B surface antigen is positive. The total hepatitis B core antibody is positive. Her IgM hepatitis B core antibody is negative. Her hepatitis B surface antibody is negative. A hepatitis B viral load, which is also reported as a hepatitis B DNA assay, is 3,000 international units per ml. Her ALT is 70, her AST is 60, both of which are elevated. As right now for women, anything ALT higher than 25 is considered high. Her total bilirubin is 2.2 and her albumin is 3.4. So how would you interpret these test results? If you have a patient look at the first line. If you have a patient whose surface antigen is negative, the hepatitis B core antibody is negative, the IgM hepatitis B core antibody is negative. The only thing that is positive is a hepatitis B surface antibody. So if only the hepatitis B surface antibody is positive, that means that the patient is immune to hepatitis B, that the patient got vaccinated and now is immune to hepatitis B, which is a good thing. Let's look at the second scenario. If you look at it, the only thing that is positive is a hepatitis B core antibody. The surface antigen is negative. The hepatitis B core antibody is negative. That's the IgM. And the hepatitis B surface antibody is negative. So if you only get a core antibody that is positive, a total that's positive, that can mean any one of the following. The most likely is that the patient was infected with hepatitis B, was able to clear the surface antigen, and this is what we call as the patient had infection in the past and it's resolved. And for most of these patients, we actually do nothing except if they get myeloablative therapy or if they get an anti-CD4 antibody like rituximab. In those settings, we do intervene in this group of patients. Otherwise, actually, we don't do anything. Also, another scenario is that this is a false positive test, that the hepatitis B core antibodies just represents a false positive test. And rarely it can represent a low-level chronic infection. That is, their surface antigen is actually positive. That is what we call as a chronic infection. You're just not picking it up. The third scenario is what we call a patient to have chronic hepatitis B infection. You see the core antibody is positive. That's a total core antibody that is positive. But look at the surface antigen. That is positive too. So if they have a surface antigen that is positive, especially if the surface antigen is positive for more than 6 months, and the core antibody is positive, it will invariably be positive. That's the patient that we say has chronic hepatitis B infection. Now, the next scenario is a patient who had infection and cleared the infection, and so does not have the surface antigen but has the core antibody and has a surface antibody. This denotes a patient that had hepatitis B infection, had cleared the infection, and will not get reinfected again because the surface antibody is positive. The scenario below that is somebody who's acutely infected with hepatitis B. And the reason you know this person is acutely infected with hepatitis B is if you look, they have the hepatitis B core antibody, but look at the next line over, they also have the IgM hepatitis B core antibody. Once you see the IgM, that denotes that that is a new infection. The IgM antibody can actually sometimes last as long as a year, but usually when you see the IgM, you know that that is a new infection. Early acute infection is that they developed the surface antigen but didn't have time to develop the core antibody. And the last scenario is somebody who has never been infected, has not been vaccinated, and so all the serologies are negative. And this is a patient that you should consider giving them the hepatitis B vaccine, especially if they are in any of the high-risk groups. That is, a man who has sex with other men, who, the people who have underlying hepatitis C, the people who have underlying other hepatic issues. These are people that you should vaccinate. So let's take a patient who, like Ms. Cardi, who you now know has chronic hepatitis B because her surface antigen is positive and a hepatitis B core antibody is positive. What are some of the ways in which you'll evaluate her now that you know that she has chronic hepatitis B infection? First is to get a liver ultrasound. And most people, if they have underlying cirrhosis or if they have risk factors for progression, a liver ultrasound with or without a serum alpha fetoprotein every 6 months. The non-invasive methods for assessing cirrhosis and fibrosis are as follows. The radiographic techniques that you can do is, we've come a long way in the radiographic techniques, and most hospitals or most radiology facilities have what is called a transient elastography. Earlier on, we used to call it a liver scan. And so that's a very good non-invasive method available for assessing cirrhosis and fibrosis. We can also do a magnetic resonance elastography or a 2D shear wave elastography, but most radiographic places have the transient elastography, and that's what I order. We can also do serum biomarkers looking for assessing fibrosis and cirrhosis, and that is a FIB4 test, a fibro test, a fibrosure or an aspirate aminotransferase platelet ratio index. We rarely ever do a liver biopsy, and a liver biopsy is really reserved for very special circumstances and usually done in conjunction with the hepatologist because of all the non-invasive methods we now have for assessing cirrhosis and fibrosis. So, what would be your next step for CARDI? This outlines the treatment for patients with hepatitis B. Clearly, the management is much more complex. It involves not just treatment, and I'll go through that as well, but this focuses on whom do you initiate treatment for hepatitis B infection. Now, usual guidelines, when you pull up and look at the guidelines, there'll also be reference to a hepatitis B-E antigen, but we wanted to keep this simple for our primary care providers. And so we are going to look at three important parameters. One, does your patient have underlying cirrhosis? And that you make with a non-invasive test that I had just reviewed with you. What is your patient's hepatitis B viral load? And what is their ALT levels? If your patient has underlying cirrhosis, irrespective of what the viral load is, and irrespective of what the ALT is, patients with cirrhosis and underlying hepatitis B should be treated with antiviral medications. And then you monitor them. You monitor them both with a hepatitis B viral load and an ALT. But it's not just treatment with an antiviral agent, it's the other things that you'll also do for the patient. Because they have underlying cirrhosis, they really need screening for endoscopy, and you really manage this patient along with the hepatologist. They will also need hepatitis C surveillance. So anybody with cirrhosis needs to have a liver ultrasound. Now, this is different from a liver scan. This is a liver ultrasound, and they actually need a liver ultrasound to be done every 6 months with or without an AFP done. Clearly, any patient with decompensated cirrhosis should be referred to a hepatologist. And you know that they have decompensated cirrhosis if they've got ascites, if they've got esophageal varices. Any of that is a sign of decompensated cirrhosis, and a footnote reviews all of that, should be referred to a hepatologist. Let's say your patient does not have cirrhosis. Then the decision to initiate antiviral therapy depends on the viral load and whether the ALT is elevated or not. The simple statement is, if the ALT is normal, treatment has shown not to be really effective. So we treat only if the ALT is 2 times or higher than the upper limit of the normal. And then we will also take into consideration whether the hepatitis B viral load is elevated or is normal. So for Miss Cardi, her treatment was initiated. As you just think, her ALT was high. It was actually 70, so it's clearly more than 2 times the upper limit of the normal, and her viral load was greater than 2,000, was actually 3,000. She was surface antigen positive, and she was initiated. And her treatment was initiated with this specific preparation of tenofovir called tenofovir diisopropyl fumarate. Many people will also refer to it as TDF because there are 2 different preparations of tenofovir, and I'll talk to you a little bit more about the other preparation of tenofovir. This comes in 300 milligrams for adults, and she started on it at 300 milligrams. You reviewed adherence with her, and she's very motivated, and she started on it. You followed her up initially more closely every 3 to 4 months. And then when she did well, you then transitioned to seeing her every 6 months. And every time you saw her, you obtained a ALT, a hepatitis B DNA assay, that's to look at a viral load. And then you got imaging for to look for hepatocellular carcinoma, and you did it annually for her. So along with all of this, counseling of her is critical. And you want to counsel her because she clearly she lives with people. Nobody lives in a vacuum. It's a family, it's a people around her. So she's going to ask you questions about what is the risk of her transmitting the virus to people around her. And this is what I would say. In countries like the United States, horizontal transmission is the most important route of transmission. And approximately 3 to 20% of persons living in households with persons with chronic hepatitis B actually have serological evidence of chronic infection, telling you that this is all by horizontal transmission. The highest risk clearly is among sexual partners and among children. But I always tell my patients, you don't transmit it simply by sharing food or utensils or hugging or kissing. Those are not the risk of transmission. Rather, transmission occurs when there's some element of blood, and that's how the transmission occurs. So it's by sharing toothbrushes, razors, or if you come into contact with blood or with body fluids. So because of this, the transmission can occur. How can we protect the people that live with CARDI or people like CARDI who are hepatitis B surface antigen positive? And that is the most important way is also by vaccinating them. So let me review with you which are the adults who should be vaccinated. First is any adult at risk through sexual exposure. So if they are partners and of patients with hepatitis B surface antigen, if they come to you, they already have a history of sexually transmitted infection. Those are people, if their serologies are all negative, that's an ideal person who should be vaccinated. And there are very strong recommendations that men who have sex with other men should be vaccinated. Anybody with a history of current or recent injection drug use. Anybody who's a household contact of somebody with hepatitis B. If you're resident or staff of facilities who are with developmentally disabled persons, also healthcare all of us as healthcare personnel should be vaccinated. And not only should we be vaccinated, we should have a titer greater than 10 international units of hepatitis B surface antibody after vaccination. Patients that undergo hemodialysis or peritoneal dialysis should also be vaccinated. And people with diabetes mellitus, especially below the age of 60, should be vaccinated. If you're going to travel to countries with intermediate or high risk, you really should be vaccinated. Anybody with underlying hepatitis C infection or chronic liver disease from any reason should be vaccinated. And the rationale for that is they already have an compromised liver. And on top of that, if they get hepatitis B, it really tips them over. So they should actually get both the hepatitis B and the hepatitis A vaccine. Anybody with underlying HIV infection, incarcerated people, or anybody who comes to you and say, I really want to be protected for hepatitis B, they should be vaccinated. Other counseling that you should give your patients is, to come to see you regularly. I always have them see a liver specialist at least once. As I alluded to before, make sure you give them the hepatitis A vaccine because you don't want them to get added hepatitis A infection on top. Counsel them to avoid alcohol and smoking, and tell them that before they start any medications, including over the counter medications, even things like acetaminophen, to talk to you about it, as well as any herbal remedies or vitamin supplements. And then you tell them that anything you eat, drink, it's all ultimately filtered by the liver. Counsel them on the importance of eating a healthy diet. And it's very important that you advise them to prevent eating raw or undercooked shellfish. This is because certain bacteria like the Vibrio vulnificus, they can get very severe life-threatening infections. That's why you tell them not to eat raw undercooked shellfish. You always ask them to look out for signs of mold on food. And then the usual healthy things like, diet, rest, and exercise, and the importance of avoiding acetaminophen and nonsteroidals. She comes back now for a 18-month monitoring visit, which is a virtual visit.
Hi, Kadi. How have you been?
I've been well, Dr. Stevens.
You seem to be doing well on your TDF. Your hepatitis B labs all look good. Is there anything of note you want to share that's been happening over the last 6 months?
Not too much to share. Things are going well. The only thing of note is that I tripped and fell in our backyard and landed funny on my wrist and broke it. That was about 4 months ago.
Oh no, I am so sorry to hear that. How was your recovery?
Oh, it was fine. Nothing out of the ordinary. The orthopedic surgeon, Dr. Jacobs, took care of me. She's very nice.
Given your age, menopause, and your medication, I'd like to get a baseline bone scan to be sure there is not deterioration in your bones that we need to be aware of. I'll give the order to the front desk and they will make an appointment for you. I should get the results by the end of the week and we'll schedule some time to go over the results.
Okay, thanks.
Hi, Kadi. We got your test results back. Let's go through them.
Okay.
We use a measure called T-score, and your T-score is minus 1.8.
Is that good or bad? Should I be concerned?
It's not nothing, but it's also not something to be alarmed about. A T-score of minus 1.8 indicates osteopenia.
Osteopenia. Is that like osteoporosis?
It is a phase on bone loss that precedes osteoporosis. Because you have chronic hepatitis B, you have some risk of bone loss related to your disease. But there may be factors outside of your disease that may be contributing to the changes in your bone density. There are some things that we may want to consider.
Like what?
What is your next step? So she's been diligent about her follow-up visits. In reviewing her history at her 18-month visit, she shares that 4 months ago, she fell. It was very thing. She really she couldn't quite explain how she fell, and she fractured her wrist. Her healing process was unremarkable, but because she's 59 years old, you order a DEXA scan, and the DEXA scan comes back with a T-score of minus 1.8. And as you know, that means that she's got osteopenia. So let's look at bone loss in patients with chronic hepatitis B infection. As a result of cumulative and time-dependent interactions between the patient's risk factors for osteoporosis, such as viral load, associated inflammation, and use of antiviral drugs. But independent of antiviral treatment, the sheer presence of hepatitis B infection actually increases the risk of bone alterations. A bone density study is recommended at baseline and during treatment for persons with history of fracture or osteopenia. Now, this is 3 years later as a virtual visit.
Hi, Kadi.
Hi.
Thanks for meeting me today. Well, unfortunately, the bone scan that you had last week showed progression in your bone loss. Your recent T-score is minus 2.9, which indicates that you have progressed to osteoporosis.
That's not good news. Is there anything we can do to stop the bone loss from getting worse?
Yes, let's discuss your options.
That sounds good.
She's now 61 years old. She has been taking her medications. She comes to see you diligently, and overall, she feels well. But you repeated a DEXA scan, and the T score now has gotten worse, and it's minus 2.9, indicating that she has progressed to osteoporosis. What would be your next step? Here are the risk factors for progression to osteoporosis. The overall prevalence of osteoporosis and chronic hepatitis B infection varies. It's anywhere from 20 to 50%. Here are the modifiable risk factors independent of chronic hepatitis B, which I told you is a risk factor for osteoporosis that impacts the risk for osteoporosis. 1, inadequate nutritional absorption. 2, lack of physical activity. 3, obesity. 4, smoking. 5, alcohol consumption. And 6, stress. Although highly effective, that is tenofovir, which is a highly effective agent for hepatitis B infection, and that's why you gave her tenofovir diisopropyl fumarate, that is TDF, because it's very effective in decreasing the viral load, keeping the viral load undetectable, and very, very importantly, people don't develop resistance even year after year after year being on TDF. That's why people use this. However, it has two very important side effects actually. One, because the dose of TDF is 300 milligrams, it leads to high concentration of circulating tenofovir, which in turn can result in both kidney toxicity and bone toxicity with long-term use. So the two important side effects of tenofovir diisopropyl fumarate or TDF is both kidney toxicity and bone toxicity. Hence, the AASLD guidelines recommend that in cases of tenofovir-associated renal dysfunction, or if they've got osteoporosis or osteomalacia, TDF should be discontinued and substituted with an alternate nucleoside analog with considerations for previous drug resistance. This is the prevalence of osteoporosis and/or fracture per 1,000 persons in both from a commercial and Medicare database and from a Medicaid database. The blue represents patients with chronic hepatitis B. The green represents patients who do not have chronic hepatitis B. And you can see that the incidence of osteoporosis and/or fracture is higher in patients with chronic hepatitis B infection. This gives you saying the prevalence of chronic kidney disease in patients with underlying hepatitis B versus people without chronic hepatitis B. And again, you can see risk factors, not risk factors, the prevalence of chronic kidney disease is higher in patients with chronic hepatitis B infection. Now, this was an abstract that was presented. Because I told you that TDF, that is tenofovir diisopropyl fumarate. Very effective, both in keeping the viral loads undetectable, preventing resistance. But I told you there's two important side effects on renal and bone. So what these investigators did is they took patients who had chronic hepatitis B, was started on TDF, that is tenofovir diisopropyl fumarate, was undetectable, and randomized them either to remain on TDF for 48 weeks or to switch immediately to TAF. TAF is again a preparation of tenofovir, but it's a different preparation. It's also called tenofovir alfenamide, and it comes in 25 milligram tablets. So patients got randomized either to remain on TDF or to switch to TAF. And at 48 weeks, everybody was switched over to TAF. And they looked at bone mineral density by doing DEXA scans and looked at both hip and spine. And what it shows you is that once patients were changed from TDF to TAF, there was improvement in their bone mineral density. In the same study, they also looked at creatinine clearance, and you can see again it showed an improvement in creatinine clearance when patients were switched from TDF to TAF, and also in renal biomarkers also showed improvement when switched from TDF to TAF. So what the goals of this CME program would be, and if I could summarize it for you, it's really to raise clinical suspicion of hepatitis B infection in immigrants from countries of high or moderate hepatitis B prevalence, and to initiate screening, because many of them may be asymptomatic and you'll pick it up only with screening. The second would be to recognize patients with chronic hepatitis B who are at risk for bone loss independent of their antiviral treatment. And third is to align treatment initiation and switching decisions to the AASLD guideline recommendations in the presence of renal impairment and/or bone loss. So today's CMEO briefcase is part of a three-part series of case-based activities that can be found on the Liver Disease Hub. The Liver Disease Hub has these activities and many others on hepatitis B, hepatitis C, NASH, and more. CME Outfitters also has an hepatitis B patient education hub with a number of excellent resources to share with your patients, many of which are translated into Vietnamese, traditional Chinese, simplified Chinese, and Korean. Thank you for joining me today. Stay safe, and thank you again for providing the best care for your patients.